Assalamualaikum. Now the clinical station asymptomatic congenital heart disease. Maybe it's a VSD, maybe atrial defect, maybe patent ductus arteriosus. After examination, the presentation maybe this is Arif, 7 years old, cooperative, pink, not in distress, well grown, no devices attached, no sign of claving, infective endocarditis or heart failure. He has pensystolic, he has a thrill at the tricuspid area, and there is a pensystolic murmur at the left lower sternal border, grade 4/6 without radiation, and so my differential diagnosis, it may be a case of ventricular septal defect, mitral regurgitation. However, it has no radiation, and it can be atrial septal defect, but the murmur is at the left lower sternal border. So I will put in the third differential diagnosis. It may be innocent murmur, but this murmur doesn't change with position. What investigation you want to do? Investigation, chest X-ray, there may be in a small VSD. In a small VSD, chest X-ray is normal. Large VSD indicates vascular marker, cardiomegaly. ECG, in case of large VSD, ventricular left ventricular hypertrophy, sometimes biventricular hypertrophy may be present. Echocardiography for the location of the defect and the size of the defect, and management. For management, acute management and long-term management. If he has any heart failure, so I will involve my consultant and manage accordingly. Long-term management, multidisciplinary team, consulting pediatric cardiologist, pediatric cardio surgeon, dietitian, dental dentist, and liaise with school support group, advice, cardiac advice, and the follow-up. And what is the medical management for moderate VSD? Medical management, diuretics and or AC inhibitor, optimize the calorie intake, follow-up, if not close surgery with 3 to 5 years. In case of large VSD, all of this management that I have mentioned above, plus pulmonary artery bending before surgery. An indication of surgery in case of VSD, if infant less than 6 months who have uncontrolled high heart failure despite the maximum medical and dietary intervention, and or who have pulmonary hypertension. If this child is less than 6 months, but in case of with trisomy 21, the child is less than 3 months, pulmonary to systemic blood flow ratio more than 2:1, subpulmonary and membranous defect, and aortic regurgitation. Types of surgery, intracardiac or transcatheter, and how to follow by growth monitoring, palpable P2, echocardiography, and cardiac advice that I have mentioned before, that maintenance of the good oral hygiene, high calorie diet, avoid piercing and tattooing, and prophylaxis infective endocarditis if needed. But if it's a cyanotic heart disease, so we have to add the advice of avoid dehydration, avoid high altitude, and oral iron supplementation. And if it is severe aortic stenosis, so we will advise for prevention of heavy exercise. And complication of ventricular septal defect, failure to thrive, infective endocarditis, Eisenmenger syndrome, and heart failure. Postoperative complication, damage of AV valve node, so heart block, arrhythmia, residual murmur may be present. This all about the ventricular septal defect. Now the atrial septal defect. Atrial septal defect, only the findings is there is a in case of VSD, I forgot to mention that in case of VSD there may be a diastolic murmur may be found at the apex. Okay, and then the atrial septal defect, here the murmur is at the left second intercostal space and it is at the sternal border, ejection systolic murmur. Then we will mention the grading, maximum intensity, radiation, it doesn't radiate. And close differential diagnosis is here the pulmonary stenosis, maybe it's a VSD, maybe patent ductus arteriosus. So, and in case of ASD, there is fixed splitting present, and then the investigation findings of ASD, atrial septal defect. Here, if in case of X-ray, right and left ventricle enlargement, pulmonary artery dilatation. In ECG, ostium secundum, right axis deviation, right ventricular hypertrophy. Ostium secundum, left axis deviation, left ventricular hypertrophy. Echocardiography for direction of the shunt and size of the defect. Investigation and then management just like the VSD, multidisciplinary team, and surgical option. If the lesion is small, less than 6 millimeters, so it will close spontaneously within first few years of life. But if it is more than 6 millimeter, surgical closure around the 3 years, earlier closure if the child is symptomatic. And the surgical option, transcatheter closure device or bypass surgery for large defect and for lesion not suitable for the device. And what are the complications? Complication of atrial septal defect, atrial arrhythmia, pulmonary hypertension, heart failure, Eisenmenger syndrome, embolism, MR, and tricuspid regurgitation, mitral regurgitation. And why Eisenmenger syndrome occur? Eisenmenger syndrome, when in three conditions, Eisenmenger syndrome may be found. This is the ventricular septal defect, atrial septal defect, patent ductus arteriosus. Whenever there is left to right shunt, there is increased blood flow, and increased blood flow causes the endothelial dysfunction, pulmonary vascular remodeling, and thereby causing pulmonary vascular resistance, a reversal of the shunt. It is called, that means the shunt will be right to left. This is Eisenmenger syndrome. And findings, investigation for Eisenmenger syndrome, ECG, right ventricular hypertrophy and or right ventricular stain. Chest X-ray, there is dilatation of pulmonary artery, there may be pulmonary pruing, and cardiac catheterization, where we can find that pulmonary artery pressure is more than 20 millimeter. And management of Eisenmenger syndrome, symptomatic management, sildenafil may be given, and definitive management is heart-lung transplantation. Thank you. Assalamu alaikum.